Last time we went over really the problem of gastroesophageal reflux as it is a problem. And some of the major points is that physiological reflux goes along with development of the GI tract and is extremely common. Indeed, all infants, if studied before the age of 6 months, will have evidence of an elevated reflux index, which, as we noted, was greater than 6% in a 24-hour period. However, in an otherwise developmentally normal infant, significant problems related to gastroesophageal reflux are extremely uncommon, and that it is really the neurodivergent population where we concentrate most of our efforts in terms of treating GER. In normal infants, reassurance, anticipatory guidance, and non-pharmacologic therapies are clearly preferable and will be successful in the vast majority of infants. We also learned that in terms of respiratory compromise, again, the neurodivergent population are those that are going to have problems related to pulmonary soilage from gastric contents, primarily as a consequence of a lack of adequate barrier function, gag reflex, if you will, that in the patient with reflux makes it difficult, if not impossible, to avoid aspiration. But again, that is something that we generally see only in the neurodivergent population. And we also have to be very mindful of the fact that many of these children, when they do have aspiration, will aspirate from above, not as a result of reflux per se. We also went over the whole concept of the apparent life-threatening event. And again, reflux-associated apneic events are extremely uncommon. And furthermore, even when they do occur in the small percentage of infants where there is a temporal association, treatment does not appear to change the clinical course at all. And then finally, in discussing the child with reactive airway disease, it is only that group of patients, primarily studied in adults, however, who have primarily nocturnal symptoms. That is the group that targeted anti-secretory therapy may be of benefit. Otherwise, there is no benefit of treating a patient with asthma for reflux just because they have asthma. The final topic to discuss before we get into treatment is the issue of laryngeal or pharyngeal reflux disease. This is something that causes a great deal of controversy between pediatric gastroenterologists and otolaryngologists, making a diagnosis of reflux based on a direct laryngoscopy. And we're looking at that population of patients who will present with a variety of upper airway symptoms that are shown in this slide. And these are really the major areas of concern. And here again, how you diagnose laryngeal disease is largely based on visual inspection and not biopsy evidence. And when that occurs, again, we mentioned in esophagitis, the absence of mucosal breaks or erosions, clear mucosal breaks or erosions, results in significant inter-observer variability when erythema is used as a guide. So this is a study done in normal volunteers, adults obviously, and this was patients who did not have any symptoms at all, but were found to have changes consistent with gastroesophageal reflux, and they're shown here. And there was, again, poor inter-observer reliability. Well, do these patients actually have acid reflux, or is it just a problem in diagnosis? Well, the results are not conclusive, but I would probably state that in the absence of really evaluating these patients, in the absence of symptoms, we cannot ascribe any of these changes to acid per se. So in those patients with laryngeal pharyngeal reflux disease, symptoms usually occur in the absence of classical symptoms of GER. The upper endoscopy is often normal, and the pH probe is often normal. Well, what does that tell you? Well, if the pH probe is normal and the upper endoscopy is normal, does it mean that the laryngeal tissues are exquisitely sensitive to even a small amount of acid? Well, that may be true. And laryngoscopic findings are the primary diagnostic criteria in these cases and are unreliable. Does that mean we shouldn't be treating these patients empirically to see if there is improvement? Well, this is the use of esomeprazole in the treatment of chronic posterior laryngitis in adults. The symptom severity is shown on the y-axis, and the week of therapy is shown on the x-axis up to 16 weeks. So here we have esomeprazole or Nexium versus placebo, and it doesn't take a statistician to tell you that there's no difference between the two groups. Again, this is the percent of patients with edema, erythema, and surface irregularity. And remember, this is non-biopsy diagnosis. This is based on visual inspection only. So, look at it here. There is no significant difference between these groups. This is a meta-analysis of available data on PPI therapy for suspected GER-related chronic laryngitis. The first study is a pooled data from 8 studies with 344 participants. The study duration was 8 to 16 weeks. And overall, PPI therapy resulted in a non-significant symptom reduction compared to placebo. And there were no clinical predictors of PPI response. So PPI therapy offers at best a modest but non-significant clinical benefit over placebo in suspected GERD-related chronic laryngitis in adults. So let's go even further. The surgery helped non-responding adult patients. Patients were treated with omeprazole for 4 months, 35% unresponsive to treatment, 10 underwent fundoplication. At 1 year after fundoplication, laryngeal symptoms persisted in 9 out of 10 patients. So again, we're left with the question, is this just because of extraordinary sensitivity to acid in the absence of a normal pH study, or could this be some other problem altogether? So clinical improvement following fundoplication is unlikely in those patients that do not improve with PPI therapy. Obviously, if you have a patient who has any one of these problems, who improves on PPI therapy and keeps relapsing off of therapy, then the question has to be asked, what is the benefit to risk ratio of long-term PPI therapy versus surgery? In the infant or child with upper airway symptoms, several studies describe the presence of GER in children with either chronic or recurrent laryngeal symptoms. Laryngoscopy is generally indicated to rule out other pathology, but there is a lack of uniform interpretation of laryngeal findings related to reflux in children and adults. Again, the problem of inter-observer variability when there is no biopsy to either support or refute your visual diagnosis. So again, these findings may be due to other etiologies. For example, allergy. Can allergy cause the same spectrum of symptoms and signs? The answer is clearly yes. So the data that's available is inadequate to allow recommendations for diagnosis or treatment of GER-related upper airway problems. Caution must be exercised in establishing acid reflux, as the sole diagnosis in patients with chronic laryngeal symptoms. I don't know if any of you have had any experience with these kids. I have them occasionally, and in general, they don't respond to PPIs. So again, surgery should not be expected to improve symptoms in those patients who don't respond to PPI therapy. So, in conclusion, before we go on to treatment, a careful history and physical exam will diagnose uncomplicated GERD in most infants. Symptom-based diagnosis is unreliable. A short course of empiric acid suppression may be reasonable in children. I'm going to go beyond infancy, after infancy, with possible esophageal symptoms. Improvement following empiric acid suppression therapy does not confirm a diagnosis of GERD. So, when GERD therapy fails, consider an alternative explanation for these symptoms. Many of the symptoms and signs of GERD can be caused by other disorders. And finally, response to PPI therapy has not been demonstrated to be effective for infant irritability, apnea, feeding disorders, or laryngeal, quote, inflammation. Other etiologies must be ruled out for blaming GER. So, Dr. Levine is much too young to know this, but I'm not. If Dr. Benowitz is on, he and I both had experience. When I started out, how did we treat these patients? We used Maalox and Mylanta, antacids. Antacids gave way to histamine receptor antagonists and then proton pump inhibitors. For a while, we were using prokinetic agents, most of which have been removed from the market for either demonstrated or alleged cardiovascular complications. And then surface agents such as Mylacon drops and other things to change surface area have also been tried, particularly in the irritable infant. The goals of pharmacotherapy should be to control symptoms, promote healing, prevent complications, improve health-related quality of life, and of course, you want to avoid the adverse effects of treatment. And we saw in a previous study that I presented on Monday that long-term PPI therapy is not benign and is associated with significant complications, primarily pulmonary. So the goal of therapy for most of these agents, not the prokinetics obviously, is to inhibit or neutralize acid that is produced by the gastroparietal cell. Around the bottom, you can see we can use histamine antagonists, prostaglandin agonists, misoprostol being a synthetic prostaglandin that's been used, acetylcholine receptor antagonist because there's a neuropathic response to acid production, and then one can use a receptor, a gastrin receptor antagonist. Of course, the pathway of histamine is histamine will lead to gastrin release will lead to acid production, and the final common pathway, of course, is the pathway of hydrogen potassium exchange via secondary active transport. And so blocking hydrogen potassium ATPase is going to prevent the secretion of gastric acid. So let's look first at the effect of histamine receptor antagonists on the healing of esophagitis. The data is very convincing, as you can see here, both cimetidine and nizatidine versus placebo. These are patients with biopsy-proven esophagitis. It's an old study, but the data has not changed. So after the H2RAs, well, the best way is to go to the source of the final common pathway, and the final common pathway here is the proton pump inhibitor, which inactivates hydrogen potassium ATPase, thus inactivating hydrogen potassium exchange and preventing hydrogen secretion into the gastric lumen. And of course, hydrogen secretion is hydrochloric acid. The gastric lumen is normally about a pH of 2, and that's because of all the acid in the stomach. So these PPIs are the most potent inhibitors of acid secretion. There have been numerous randomized controlled trials that show that PPIs are superior to H2RAs in relieving reflux symptoms, and they're effective in patients unresponsive to high-dose H2RAs and superior to H2RAs in maintaining remission. And they have a very good safety profile if used over a limited period in ages down to 1 year of age. So there have been pharmacologic studies of omeprazole and lansoprazole, but not placebo-controlled trials, and multiple case series of children refractory to H2RAs. And if we look at the pharmacology of omeprazole, keep in mind that when I used to see patients who were on any of these drugs, they usually were underdosed because the PK in children, and the third bullet down, suggests that children have a higher metabolic capacity than do adults, and that the metabolic capacity in childhood is higher with decreasing age, so that a higher dose per weight unit of drug is required. So down at the bottom, you see that esophageal pH less than 4 for less than 6% of 24 hours was achieved in 72% of 57 children with doses of 0.7 to 1.4 milligrams per kilogram per day. So those are about 1 milligram per kilogram per day is the dose level that most young children will need to achieve in order to effect a reasonable reduction in acid production. Many case series of esophagitis in patients, children treated with omeprazole, and as you can see here, over to the right, good clinical response. Down at the bottom, Eric Hassel, who did a lot of the original research on this out in Vancouver, found that esophagitis was healed in 57 patients who had biopsy-proven esophagitis with symptomatic improvement in 95%. So in those children who require therapy, and that therapy should be based on biopsy evidence along with symptoms, there is marked improvement.
Hey, Steve.
Excuse me?
Can I ask a controversial question?
Sure.
You know those patients who get diagnosed with, quote, silent reflux and then seem to respond to PPI?
Yeah.
What is your thought on that?
Well, who's diagnosing silent reflux, and on what basis are they diagnosing silent reflux?
Great question. I've had pediatricians do it. I've had developmental pediatricians do it. I've seen a couple of gastroenterologists do it, but based on clinical, they're not scoping these babies.
Annie, I don't know. I mean, I've had this all the time. You know, those are the kids. A lot of the kids with silent reflux. Yeah, you know, those
are the really irritable babies who spit up all the time, and
irritable babies who spit up all the time. That's not silent reflux.
Right, that's fair. That's not silent.
That's reflux. And I think that pediatricians, I don't want to cast aspersions on pediatricians, but the quickest way to get the patient out of the office is to give them a prescription.
And then they grow out of it anyway, and everyone attributes it to the medication.
And they grow out of it anyway. So you're a hero. The child comes in at 4 to 6 months, which is the typical age that they present, as I showed you on a previous slide.
Right.
The child gets treated for 2 months Oh, the
Better.
pediatrician is a genius.
Right.
This you've just looked at the natural history.
One of the places that I practiced had a like specialty colic clinic that was like notorious for doing this. And I always wondered if there was like something I wasn't understanding. Just wanted to make sure.
Well, here's the mantra that I was always taught. Babies with reflux regurgitate. Older children, adults with reflux don't. So if I have a child who's colicky or irritable and is not spitting up all over the place, I'm not going to make a diagnosis of reflux. Could it be calcium protein allergy? Could it be sleep deprivation? When I was at CHOP, one of our community pediatricians did a really terrific study looking at infant irritability, nocturnal irritability, daytime irritability. What he found is every time the baby cried, the baby would get picked up and rocked and carried around. And so what ended up happening, this would go on at night. And so because of this, the infants have sort of a day-night reversal and would sleep during the day and be up all night. And this was all behavioral. Now, I'm not suggesting that all of this is behavioral, but there are a lot of things that cause infant irritability. In the absence of clear evidence of vomiting and regurgitation in an infant under 6 months of age, I have a lot of problems making a diagnosis of gastroesophageal reflux as causing anything.
Thank you. I appreciate it. Sorry for the digression.
No. This is the stuff that's important because this is real life events that occur. So again, these are children with esophagitis, heartburn, dysphagia, irritability, coughing. The green bar is at study entry. The pink is 5 to 14 days. The orange is at 3 months. Read it for yourself. And omeprazole on esophagitis. This is very interesting. Looking at varying dosages, only 44% of children were healed with a low dose, 0.7 milligrams per kilogram per day, 72% with a milligram per kilogram per day, and 95% with 3 milligrams per kilogram per day. This is why I always state, start at about a milligram. Don't go below a milligram per kilogram per day because you're not going to have a reasonable response. You may have a partial response with 1 milligram per kilogram per day and then may have to increase the dose. Okay, in terms of lansoprazole, the PK values in children are similar in general to those in adults. Again, there was a trend toward more rapid drug elimination in infants than in adults. And the anti-secretory effect may be higher in infants less than 6 months than in older children. Again, the esophageal pH is less than 4 for less than 6% of 24 hours. Remember, 6% is the reflux index we're looking at. In 7 of 8 children with erosive esophagitis and 9 of 14 children with non-erosive GERD with 15 or 30 milligrams daily for 5 days. So we give it initially once a day, and then again with a partial or non-response, we can double that and give it twice a day. So this is the lansoprazole. Esophagitis healed in 17 of 35, 12 of 15, improvement in heartburn in up to 70%, symptom resolution or improvement in greater than 70%, with 100% healed. So again, very effective. And if we look at the effect of lansoprazole on GERD symptoms, again, baseline week 2, week 12. Look again on esophagitis, week 8, 22%. At week 12, completely healed in all children. So if we look at the labeling, I don't have to, we can skip this slide. Again, This is just the oral PPI dosage, you know, I think you've all are familiar with this. For esomeprazole, lansoprazole, omeprazole, pantoprazole, and rabeprazole, we all have the favorites that we use, and just be very familiar with one of them. I always use lansoprazole preferentially, but you know, each individual attending may have their own preference. One of the nice things about lansoprazole, Annie, does it still come as an oral suspension or as a powder that you can mix?
I don't know about lansoprazole, but I do think that one comes as the dissolvable tablet, which is nice. The question is always, is it covered?
Yeah.
I think esomeprazole also comes in the packet as granules that you can sprinkle, which is also nice. But usually if one of those isn't covered, I'll just tell them to open the capsule of whatever is covered if they can't take pills.
Open the capsule and sprinkle in applesauce.
Yeah.
It should be given in an acid environment. That's why you use applesauce. Don't do it in you know, sugar or something, I don't know, maple syrup, whatever. You want something that's really quite acid. So that's why applesauce is preferred.
I do find that if there is a suspension, it's usually not covered because insurance companies don't care about kids.
Yeah. Yeah, I you know, what I've often done is just go to the applesauce. It's just much easier.
The real problem is when it's a G-tube patient, because the granules will clog the tube sometimes.
Yeah, yeah. So the optimal time of a PPI dose is a half an hour before breakfast, and if it's a second dose, a half an hour before the evening meal. You want to block all of those receptors. You want to block the hydrogen-potassium exchange before the stimulus of the meal. So it's all blocked so the meal can act as a stimulus. So always half an hour before breakfast, half an hour before the evening meal. In older kids, I used to tell them, keep a glass of water and the pill by your, you know, on a nightstand by your bed. As soon as you wake up in the morning before breakfast, do that and then go for breakfast. They have good safety profiles. A wide variety of symptoms have been associated with it. Again, this is something we rarely, if ever, see, certainly in relatively short term. I'm talking about treatment for let's say 3 months. They're very, very well tolerated. It's the long-term therapy that you're more worried about. So current evidence supports the use of these anti-secretory agents to treat reflux esophagitis. Effectiveness for other GER manifestations is not well documented, except those that we previously discussed. Again, all of these studies, when they're done, you should have consistent delivery methods and optimal dosing. Again, the questions of effective long-term acid suppression in the developing bowel have not been addressed, and one must be very cautious before prescribing any of these drugs to in the infancy period. Prokinetics, all right? Well, I would like to ask Dr. Levine, since she's, what's your experience with erythromycin?
I've used it a decent amount, but not for reflux per se.
Yeah.
Yeah.
Well,
like I use it for kids with motility issues for
right.
sure.
Well, if you look at this, if you look at the studies are pretty good in preterm infants. Erythromycin is a modulin agonist. Fellows, be aware of that because that's always on the boards. Why use erythromycin? But as an agent to be used in older children, I don't believe there's a lot of convincing evidence of its effectiveness. And I remember Carlo Di Lorenzo always used to say, don't use subtherapeutic doses. Use therapeutic doses erythromycin if it's going to work. Again, I was first taught to use subtherapeutic doses. These other drugs, cisapride. Annie, did you ever use cisapride?
I've
Probably
never
not.
used Cisapride, but I worked with Sam Nurko for a while, and I think he had one of the last remaining licenses to use it in the United States, and he would really only use it for kids with like pseudo obstruction.
Yeah, well, cisapride, when cisapride was taken off the market, we all cried because it was
Right.
amazingly effective. And it was taken off the market because of cardiac events in adults that could be predicted on the basis of an EKG before therapy. But again, it's gone. Domperidone is a similar drug. I believe it's still available in Canada. There are no randomized control
I also think
trials.
domperidone's available for adults in the United States, but not children. Like a lot of EM physicians like to use it for cyclic vomiting.
Yeah. And my absolute least favorite drug of all time.
Ha.
You would agree?
Yeah.
Metoclopramide. Metoclopramide, fellows, look it up. Interesting drug. And the use of it is highly controversial. There have been 4 randomized controlled trials. Only one of them showed clinical improvement. There's a very high incidence of adverse events. And the one group of children with the most severe symptoms related to delayed gastric emptying and reflux are the one group you do not want to use this drug in. And that is the group that is neurodivergent, because it can cause tardive dyskinesia, Parkinson-like symptoms, motor restlessness. It can also uncover a seizure disorder. So seizures have been described with it. In general, we stay away from it, except in very unusual circumstances.
It's not a great drug. I've only ever used it as like a 3rd or 4th line for like intractable nausea and vomiting. And I also always give it with Benadryl because of the concern for dystonia.
Right. It is. But it's used a lot.
Some
Still
people
is.
love it, unfortunately.
So again, sort of giving you a fairly quick overview. It's going to be a short lecture today. One can choose either a step down or a step up approach to therapy. The step down approach would be begin treatment with a PPI, maintain improvement, encourage diet and lifestyle, and limit the length of treatment. And this is probably a good idea in older children who have clear GER-related symptoms. If a child comes in with heartburn, particularly if they have an infant history of spitting up a lot, because the presumption is that reflux doesn't just happen. It's a problem that begins in infancy and just persists. Those are patients that I have no problem, never did have a problem beginning treatment with a PPI while encouraging diet and lifestyle. In younger children, certainly in infants, smaller, more frequent feedings in the child older than 2 months of age, one can use a thickened formula. If they have an inadequate response, you can treat them with single dose PPI. With an inadequate response to that, double dose PPI. And one can go as high as 3 milligrams per kilogram per day, but I would start at 1 and then probably go to 2 milligrams per kilogram per day if there's an inadequate response. And that's the end of reflux.